This conference will now be recorded.
Thank you. Welcome everybody. Happy New Year. Welcome back. I know we skipped the meeting in December, and I think that's okay because we were doing a lot of work on the one-on-one stuff, and now we're back on track for this month. So as a reminder, these are the 10 sites that we're working with. And the first thing on our agenda is for us to go over our milestones and kind of see where we are. So the first thing on here, and Michelle Price is going to help keep me on track for this part as well. The first thing we see on here is we finally got almost all the paperwork done for kind of the basics. The contracts are all signed. The IRBs are finally all done. I think we had one more pending last time we met. The data use agreements for sharing the data between your university over to Johns Hopkins are almost all complete. There's still one that's back and forth with Utah, which I think we're getting close on. But this part is moving ahead, which is great. And then on the next slide, I think what we're going to do before we get into the meat of everything, just remind everyone, you know, this project is over a year into it. And we've done a lot of really, really good work, but I think it's all been a lot of this preparation work. And I'm pretty excited to see some of the sites actually get up and running with the alert and then the actual intervention to see what we can do about actually rolling it out at some of these places. So over the next few months, that is really our true goal, to have the next steps moving forward. So for now, what we're going to do is we're going to talk about the progress update on kind of this step of the project, which is finalizing the medication list, getting the preliminary data to us over at Hopkins. We're going to start looking at some of that preliminary data to kind of see what the baseline looks like. Those are kind of the first two things we're going to talk about. And I'm going to turn it over. I think, Brandon, this is you to talk about where we are in this list. You and Peggy.
Yes. So we have met with sites to talk about the medication identification. So the process of this, just in brief, goes in a very specific order where each step builds on a previous step. So medication identification, how you document VT prophylaxis at your site, is then used to populate a list of 1 month or a few months of data to see if you're actually pulling the information for individual doses of VT prophylaxis, along with additional fields related to each dose: patient information, nurse information, location information, administered, not administered, reason for non-administration. That test data is a way of validating the medication list that you've developed in step 1. After you've validated that list, pulling 2 years worth of VT prophylaxis registry data, along with your trauma registry information. So far, we've sent out to 7 different sites links to secure folders for uploading the VT prophylaxis registry information. There have been a few people who have reached out who had issues with accessing the link that we've sent back to, but that is available for everyone who has their data person at their site identified to upload the 2 years of VT prophylaxis registry data and trauma registry data. Once you receive that link, then step 4 is uploading that information, sharing with us.
Maybe it would help if we go to the next slide. The next slide is kind of the nitty-gritty of where each site is, Brandon.
So
yeah, go ahead.
We've met with more than half of the sites to talk about the medication list, to have one-on-one meetings to talk through the medication list or preliminary data. I think that those conversations are extraordinarily helpful, being able to see what you're actually pulling, Most places are on Epic, so the reports that are getting pulled where it's one line per dose of VT prophylaxis, talking through any issues, I think is very helpful, having these one-on-one meetings and recognizing that the data should be pretty standard across different sites. Then after that initial meeting, pulling 1 month of test data. As you can see, only 2 sites are actually there. And then having set up for each individual site the folder to upload 2 years of data. And thus far, we haven't received the 2 years data from anyone as of yet, but there are 7 sites that do have access to upload the 2 years of data.
So I guess my first request would be that column that's called the data contact provided. That was an ask from Lizette. There's still a few sites, and this is just to make sure we have the right person who needs data access. This might be the trauma program manager. It might be an Epic person. It might be if you have a research coordinator doing this, the person who's going to actually take the actual file of data and put it into the secure, shared drive that we'll be able to get access to. So we just need to know exactly who's going to do that. Hopefully we can get those things ready, even if you're not ready to share the data, just so we know that we have the right person, the contact works, the link works, et cetera. So that column we should be able to do relatively quickly. We still have a few, sorry, go ahead, Brandon.
I was just going to say it's important to make sure to talk to the team, because there has been at least one instance where the person who was initially identified is no longer at the institution. So people do turn over quite frequently, especially people who you might not interact with frequently.
And hopefully that's not the case for like your main research person or something like that. But if there's an IT person that you think is going to be doing this, that might be a problem. So I think, who's going to be doing the data piece is part of it. And then as you look over the list, if there's a place, if there's one of the sites that you think you've already done something that's not delineated on this checklist, now you can chime in right now. You can send me, Brandon, Lizette an email to say, hey, I thought we were here, et cetera. There's a few more places we do need to get these one-on-one meetings set. And like Brandon said, they've been very, very helpful to talk through the nitty-gritty of how this actually happens. But these are these key steps that need to happen, because until we know what the data looks like, and until we've kind of given it the thumbs up and we've all agreed that it looks okay, you can't really construct the data set to share with us, and you certainly can't construct the real-time alert. So I think this all is pre-work for the real-time alert. Peggy, I know you had gone back and forth with some of the sites about, what are the right medications, how do we list them, et cetera. I don't know if there's anything you wanted to add to this discussion.
Thanks, Elliot. I think what I would just remind people is we decided that we weren't going to do any oral anticoagulation meds for DVT prophylaxis, so just the injectable. And it has been helpful to go over the list just to make sure we have the right heparins and enoxaparin, because I know with some of our discussions, we had to get some of the data that was pulled fixed, and actually pulled in a pharmacist with Christiana. And I think hopefully they're going to be helpful with that group as well.
And that is a great point. Originally we had planned we were going to be including a bunch of these oral meds, whether they were aspirin, if you're adding it on for some general trauma patients, or some of the other oral agents that are being used for orthopedic trauma. We've decided as a group, as a reminder, that we're going to just go with the injectables. That's the focus of the education. That's the biggest risk we see of patients missing these medications, and it's the highest volume. So it just made sense pragmatically to just go with those. So if any of your hang up relates to those other oral medications, we can certainly get that going a lot more quickly.
Yeah, and I did receive the data contact also from Christiana, so I'll add them in and send it over to Brandon. So John, we'll get those emails out to you.
Thank you. So anybody, any of the sites have any comments, questions, issues, things they want to bring up, things they want to ask related to this, the data pieces? What could we do to help? And I'm not surprised we're not getting a lot of questions. I will tell you that each time we meet with a site one-on-one, we learn new things, we get asked different questions. Sometimes there's some overlapping questions, but there's a lot of, my site is a little different for this exact reason. So I think that has been very, very helpful. And what we'll do is we will work harder now that it's into the new year to set up times with South Carolina and Oregon, which are these one-on-one meetings that we can get going with.
I would ask that if there's a site that is ready for an additional meeting to be set up with Dr. Howard and his team, that you let me know. You can just send me a quick email or just let me know so that I know that that's something we need to work on getting that set for you. And then
Absolutely,
also,
it's a great point. It's not that you had one meeting and then that's the end of it. If you need 2, 3, 4 meetings, whatever you need for us to go back and forth on what does the data look like, is this right, does it make sense? Before we go to the next step, we're happy to meet anytime.
yeah, and then South Carolina and Oregon, if you're ready to get your meeting going, let me know and we can get that on the schedule as well.
Ellie, this is Rosemary Kozar and Lizette. We did have some issues with pulling the data, but we found a plan B that will work and work within the budget, I believe. So major problem solved, I believe.
Okay. And if you want to just shoot us an email, if that's something, or if you want to, I can just talk to you by phone. If there's anything you need to tell me later.
Yeah, no, I think we got the problem solved. That's all, just because I had contact with Lizette. Thank you.
Perfect. Thank you. And this is, as you know, this is implementation science. It is not a randomized trial where everyone's on the same exact protocol at every site, et cetera. And some of these issues are things change all the time. We totally understand it, but we do need to move the project forward as well. So it's that tough balance. So if there's no more questions on this topic, I think we can go ahead and switch gears and move ahead. So the next step, once that part is done, this is the real-time alert. Brandon, you want to kind of walk us through what the next steps are, which we're getting close to?
Sure. So once you've actually validated your medication list to ensure that the VTE prophylaxis regimens are documented appropriately, you're able to pull data on it to get information of what is administered, what is not administered, that it is 100% accurate. That's when you would start beginning the actual build. You need that information to know what to alert on, where to alert, where to trigger the alert, and how it's documented as non-administered. If it's missed, refused, if it's just not given, and some subsequent, you need that information from building your VTE registry to know what to build in your alert. However, until then, there are several steps that need to be taken to ensure successful implementation of the real-time alert. First, identifying what communication devices your site uses for sending real-time alerts for other things. Trying to incorporate it as much as possible into the regular workflow will probably lead to a more seamless implementation. Identifying exactly what your patient population is, if they're on a specific floor, if they're on multiple floors, who is it that's going to receive those alerts, and if they're in multiple locations, is a person expected to go to multiple different locations, or would you potentially have devices that are handled by individuals in each of those locations? And then exactly who it is that's going to receive it and when, and how you're going to go through the steps of delivering the intervention. The way that we've implemented it previously is that largely charge nurses were holding the communication device and would go and intervene when we were trying this. If that doesn't necessarily work at your site, trying to identify exactly who it is that's going to be receiving the alert and how they would intervene, to understand what the implementation is actually going to look like is going to be very helpful. These are all steps that can be done before the actual build takes place.
So I'm just going to add a couple things on top of what Brandon said, just to reiterate some of these things. You know, what we've learned is it's not going to be the same at every site. And that's probably the number one takeaway. And these options that are available at each site are very, very different. And what Brandon said, that it's what your nurses are used to using already is going to be the best platform for this. So if they already carry a pager, we just have to figure out a way to get this to their pager. If they have a phone that's already connected with their Epic, that's what we want to be getting into. We want to be able to make it seamless so that it's not a whole new device that they're not used to. So that's the first piece that goes along with bullet one. Bullet two, you know, we've talked about this, and it's mostly floor-based interventions. We're going to talk about it a little bit later, that some of the places originally thought they were going to do all these floors, and then they're now down to a smaller number of floors. Some places are 1 floor, some are 2 floors, some are 3 or 4. But the key is making sure exactly that we know which floors they are, because that's going to help your build people. And then it's the logistics of how it's going to happen. But I think those couple things up front are really important to figure out how you're doing the alert and then where you're going to give it, because then as you talk to the person who's building this alert, they will need that information to do the technical pieces that you're going to need. And then the last piece really is that it's a combination of technical, and then, okay, now we're ready to go. We get a pager or we get an alert to our phone. Now, how do you get the nurse to be actually doing that piece? So does this make sense to everybody? Are there any comments, questions, things you want to talk about, things that you might have come up with as a question that might apply to other places? Anything else we can talk about here amongst the group? Quiet group today. Or everybody's accidentally on mute. I mean, I'm hopeful that it makes sense to everybody. And as you meet with your team who's going to be doing this build, hopefully they've been asking you some of these questions. If you haven't started meeting with that team that's going to be doing this piece, even if you don't have your data ready and your exact list of medications, I implore you to get in touch with the people and try to figure out who that's going to be. It's often different than the people who pull data from Epic. It's the ones who are doing the build within Epic. So if you haven't started this piece and started down this route of, hey, what are we going to do? How are we going to do it? That really does need to get started kind of ASAP.
Hey, Dr. Howard, it's Joanne from Lancaster General. We've going through pretty much every step so far. This has been our hardest point to successfully complete. We're not really sure what we're going to do, whether we use a pager, we use mobile heartbeat. It's just there's no electronic connection between our mobile Epic and mobile heartbeat at this point here at Lancaster General. They do have something coming in the future, but I'm working with nursing leadership to narrow that down, whether it be a pager or the nurse call, the dynamic role of that unit. We have the process per se down, but it's the actual how to do it. So I think our team has met with your team to discuss it. But I have a meeting the end of this week to see if we have a final conclusion on how we're going to do it.
Absolutely, and I appreciate all the work you're doing, because I think you're a little bit ahead of some of the other places. Like we said, this is not going to be the same at every single place. So, when we did this originally, we had a dedicated pager that was only used for this project. And that might be a possible option, especially if you're on 1 or 2 floors. That might be a reasonable option. It might not be ideal, but if there is no other technological approach, maybe a pager is a way to do it. Some of the other places have a connection directly from Epic, and it can send messages to phones via a bunch of different third third-party software, et cetera. If your site is already doing that, trying to glom onto whoever's doing that is probably the right maneuver. But like I said, there's 10 different sites. There's 9 different Epic sites, and I will be surprised. I'd be shocked if it all happens the same way. I'm fully anticipating, 5 or 6 or 7 different possibilities. A few places might do it the same, but in general, I understand. And we knew this was going to be a pressure point. So don't be surprised that this becomes a pressure point. So that's why I said, if you haven't gone down this pathway and really started talking about it, I do need you to get started on this, talking with nursing, IT, what are the options, how are you going to make it happen, et cetera. So thanks for working on it. Is there a site that's made more progress? Is there anyone on here that is willing to kind of chime in and say, hey, we've done this, and here's where we are? I will say when we had one of the meetings, and Rosemary, I think it was actually at Maryland, we had your nurse practitioner who was also the Epic report or Epic, one of your Epic builders on the call. And I thought it was pretty helpful that they asked some good questions, and it seemed like it was the right person. It was this interesting mix of a clinician who knew how to build stuff in Epic.
Yeah, we're pretty fortunate that we have the one person that could do both.
So I think, if you can ask around at your place, maybe there is someone, on a different service and a different service line. Maybe they're not in trauma, but they're somewhere else in surgery or some other capability that you could use a little bit of budget time to help, offset their cost and utilize their skills to try to do this. This is where trying to figure out the options, I think, is really important. So I don't think there's much else if no one else has anything else to add there, but I think, get started with it. And what we might do is ask for some email, just traffic of how's your progress, what are we doing, et cetera, for the alert. Next up is the nurse education module. Kind of progress, where are we, how are we doing? I think Ashley's going to give us some numbers and kind of walk us through kind of where we are on getting the nurses educated.
Yes, so from the last meeting in November, we've seen some increases in the nurse education at all of these sites. I do want to draw your attention to the project's overall total, the actual project total at the bottom. So it did decrease from 1,900 to 1,617. This is because the University of Maryland reevaluated and adjusted their site target number from 400 to 117 completers. So with that new project number, we currently have 715. So out of 1,617, we currently have a 44% completion rate across the board. So we do, and we are continuing to include those extra completers that were at the University of Maryland who are no longer a part of the target number at the bottom there, so that we can keep that all module completers number consistent with our post-education module survey. So that's a little bit of an update to the table since the last meeting. Are there any questions about that?
So I just want to make sure everyone understands, sorry, my dog is barking in the background. Maryland changed that they were going to have almost 400 nurses and moved it down that number because they targeted a specific number of floors. And that change, I think, was a very well thought out, well planned idea, so that you can't attack the whole hospital. You're going to attack a couple specific floors. I've been talking about to San Francisco about doing something very similar. So I think that number of 450 at that site is also going to drop in the same way. I think that gives us a much more realistic target and a realistic way to get this project up and running. Turning this on at 9 different floors across a whole range of places is going to be really, really difficult. Focusing our efforts in a certain area is going to hopefully be able to fix this for us. And what I would point out is in that far right column about percent completed, there's a lot of sites that are doing really, really well. 4 sites are in the 80s. There's a site in the 70s. There's a site in the 60s. So once Maryland figured out their thing, I think they're going to get there, and they're making progress. They're about a third of the way there. Then the sites in San Francisco, Wisconsin, and South Carolina, we do want to see those numbers start to move. They've slowly started to trend up, but it'll be pretty exciting once that really gets going. I don't know if any of the sites that are in those groups want to talk about kind of what they've been doing. I know a few of them just got started, but if there's any comments or questions, now's the time. And then if there's any issues about the data, we're trying to keep it as clean as possible so we have the right denominator, but we also don't want people in the numerator who aren't in the denominator. So we thought this was the cleanest way to do it for people to see it.
Elliot,
John,
Rosemary, oh, I'm sorry.
go ahead, Rosemary.
Oh, no, I was just going to say, if there's anybody, like any of the if the centers are on there, any suggestions would be welcome. We are struggling a lot.
I think so. We have done that in the past. There was one of these meetings, and it was recorded. I think the Stanford group gave us some ideas. I mean, the general gist of it has been, especially once you target it down to a couple specific floors, the advice I remember is having some of the trauma surgeons who are involved, like on rounds, talk about it. I remember Dave Spain saying, hey, who's done this education? It sounds great. We're really excited for it, et cetera. Rosemary, whether it's you or someone else that they look up to, when the surgeons ask for it and say it, that might be one specific piece. And then the other piece has been the targeted asks from, for example, nurse managers or nurse educators on each floor. Hey, Rosemary, I noticed you haven't done the module yet. Can you plan to do it within the next 2 weeks? Those are 2 specific things I remember, but if there's anybody else who has ideas, we're obviously willing to share.
Elliot, separate question.
Sure. So before we do that, I see Dave Spain responded that he reminded me it wasn't just him, it was Lisa Knowlton, who's also their PI there as well. So I think, it doesn't have to only be one specific person, but if anyone on the team, I mean, whether it's the trauma surgeons, whether it's the nurse manager, trauma director, whoever you think is the person who's there on the floor that could help convince people, that would be the great way to go. So if nothing else on that, I think we're going to switch over. John, you had a question?
I did. So I've had a bunch of nurses, we noticed this about 2 or 3 weeks ago. We had a bunch of nurses that got on, registered, and were showing up in the reports as not complete. And some of them truly, in talking to them, did not complete. But we're also finding some of them that are stating that they made it all the way through, and for whatever reason at the end, they either didn't stay on long enough to get to the survey or got knocked off at the end and then had to redo the whole thing again. I'm trying to figure out at what point in the module does it actually give you credit? Because there's no screen, at least in what I've seen, it says you've completed, do you want to go on and do the survey? Because I'm trying to figure out if my people are just not waiting long enough at the end before they log out and they're doing the whole thing and I'm making them redo it because they're not getting credit.
I'm going to call on Doreen, who may or may not have an answer for that. But if Doreen doesn't have an answer, we're going to have to go back to the actual learning management system people and try to answer that question. Doreen,
go ahead.
So my experience with people who are having trouble completing it have missed a slide or have missed a section that they haven't done all of the asks of that section. And if it's not that, then it's going to have to be a learning management system answer.
Yeah, because I know my nurse educator on the floor, I think actually had emailed you guys on in a link. There's a link, if you have questions. Mm-hmm. And I think she emailed, and she's not heard, at least as of last week when we were talking, she'd not heard anything back from that. And I know we've had at least 2 nurses that we've identified that by their statement have finished everything, and show up as registered but not completed. And I'm just like, with as tight as time is right now, it's really hard for me to go back and say, I need you to do it again.
Mm-hmm. And the other
John,
thing is if
if you send me an email and you can copy Doreen, or if you don't have her email, I'll get it to her with the specifics. We can certainly do that. The emails through the module, like through that site, go centrally to the learning management system, and I don't know that we get those.
Okay.
I can talk to them and ask them about fixing that issue, but I think in the meantime, if you send an email to me, we can work on it and try to figure out what the issue is.
Yeah, because I
and
know even when I did it, it locked up on me. I tried 3 different browsers because when I did it, it locked up on me 3 times. It actually took me 3 times to get all the way through to the survey at the end.
it will be helpful too if you give us the names of the learners.
Okay.
And then the learning management system can kind of track back through that way.
Okay.
Yeah, I think we can certainly look into that if you give us the specific information. I mean, it's certainly not perfect, but that being said, I think we are seeing, 800 people who have been able to complete it. So if there's something we can fix on our end or some education we could give on,
Well, and
something.
I'm even wondering if it's something on our end, because is anybody else out there having this issue?
John, I will say that if you have the link embedded into like your own learning system within your institution, we found there was another site that had an issue with that. And so if you don't have it that, and they really are just getting to the normal link and trying it that way, you shouldn't have those issues because no one else has had them. But if you will just send, we've worked with Lancaster specifically on this issue and worked out the kinks. So if you can just send us a couple of the first name, last name of the learners that are impacting, we can work right through them. And they're pretty good on a quick turnaround.
Okay.
Yeah, so John, if you copy Lizette on that email too.
Okay.
And
I'll send it to you and Lizette, Elliot.
Okay. Perfect. Any other questions about the education? I just want to make sure people understood how the data look and the numbers. Making
Yeah,
sure.
Dr. Hawk, this is Bobby Kosker from Utah. So
Yep.
Dr. McCrum and I are noticing that when we get our weekly reports of the notifications for the nurses who have completed their training, it seems to be a lot lower than the reports of the nurse managers that they are giving us for the amount of completed trainings. And we don't know why that is. We initially, I believe our SICU is all totally up to date, but there's our other floor that we're using. We ran into an issue first that they try to do it as a group training, and then we had a discussion and they said that it was individualized. And so as far as of the first, I think the first week of January, I spoke with the nurse manager and she said about 90% of them had completed the survey, but the last one we got back said we only had about 67% of retention for for the education, and we're not really sure why that is.
Sure. So what we can do is, and we probably just need to start an email thread going back and forth, and we can literally look at the list you have and the list we have, and to see where it doesn't line up and see what the issues are. If you want to send us an email, we can have our group pull, same thing, send an email to me, Doreen, and Lizette, and we can have our people pull the list from our end, you can pull from your end and see where we're missing them and what the issues are, especially if the nurses say they've completed it, Elliot, how it completed it, and it said I did it, here it is, and we don't have it, we can try to figure out what the issue is.
Okay, excellent. And then we also had a question that was kind of unrelated to this education piece, but and I know you've gone over this multiple times, but could you just also differentiate, so the medication list, is that the pull that we're doing from Epic, and is it a single step process or is it a 2-step process? So initially we're doing one pull to see what medications we're using for VTE prophylaxis, and then we're doing another pull to see how often or the frequency that they've been prescribed within the last 2 years. Is that correct?
So sort of. So I think it is a multi-step process. The first step is we know the medications. For example, you use enoxaparin. So we know it's heparin and enoxaparin, and we know it's given at lots of different doses and frequencies, et cetera. So the first step is really translating, the clinical into how the Epic people will be pulling the data. So that's this translation of, whichever whatever the actual wording is for heparin. It might be heparin unfractionated, unfractionated heparin, et cetera, et cetera. It might be, Q8 hours, or it might be at this time, it might be, et cetera, et cetera. So the first part is taking the translation of this is what we as clinicians, docs, nurses, pharmacists think we give versus how do we pull it out of Epic to match their wording. So that's kind of the first step. And if you want help with this, we can certainly meet again or go over this again. We've sent out a few of these different documents. They're on the website of, here's an Excel spreadsheet. Here's what it looks like. Here's what the Hopkins version looks like. Here's what a generalized list of the medications looks like. And then please fill it in to turn it into what your medication looks like based on the wording in Epic. That's kind of the first part. Then once you think you have that pulled, then we would look at that list, pull some data, see if it makes sense. Hey, if you've got this many patients, how many doses do you have overall? Do we feel like we have it right? And then once we have that, that's when then you would go back and pull 2 years worth of data. And the data for that are every single dose that's ordered on your trauma patients, and is it given or not given, and the reason why. And we have all the specifics laid out, but I think those are kind of the generalized steps to getting that med list up and running, and then being able to pull the data from Epic. Brandon, did I cover that okay, or did I miss something?
Yeah, excuse me, I think that covers it nicely.
Okay. So does that,
Okay, excellent.
help answer your question?
That's really helpful. Yeah, that's very helpful. Thank you.
Set up, we can set up a one-on-one meeting, and we can bring any combination of, I'm certainly not an informatics person. That's where Brandon comes in and super helpful. Peggy's our pharmacist who's been doing this with a lot of the other sites, helping, translate, like I said, the medical into the IT side. We can certainly do some back and forth via email or the meeting that we could get set up.
Okay, yeah, great. I know Dr. McCrum is on the call as well too, but I will chat with her a little bit further and see if we want to just do an email thread, or we could set up another one-to-one as we kind of progress and start getting farther down to where we start pulling the medication list. But that was helpful. Thank you very much.
Sure, thanks. Okay, any other questions related to nurse education? Okay, so next up, I think Doreen and I are going to talk a little bit about the prepare for launch part. Are we ready to go? So Doreen, you want to kind of go through some of this stuff, or you on?
I'm on. Okay, so just want to make sure you guys have access to the customized badge materials, the cards, posters, and then postcards. Elliot, now I'll need help with this. Is they're able to customize them for their own site?
Yeah, so Lizette has been working with them, and hopefully this is moving ahead. I realize the poster is small, but that little red box at the bottom, that's the spot where you could put your hospital logo, your hospital, the specific medication policy number might go in there. That's the part where you can customize. The little badge cards, we decided not to because they're pretty tight on space already. That's the two things you see in the bottom of the screen right here. That's the front and the back of these small laminated badge cards that you wear or behind your ID. And then we also came up more recently, that badge card has a QR code that someone could scan with their phone if they wanted to go to the patient education materials. It was suggested and requested by one of the sites that it'd be nice to have a handout of some sort that we could give to a patient. So that's what this badge, this last piece looks like. It's that orange card at the bottom. That's the front. The back of it has two different QR codes about how to go and get more information about this. Watch the video, go to the printed materials. That's what this is going to look like. That are going to go out to everybody, and hopefully Lizette has been in touch with all of you to get you your information, get these things printed. Like this should not be a giant holdup. So that when everything's ready, and once the alert is ready and you're ready to turn it on, then you're ready to go. Here's the badge cards. Here, nurse, take a badge card. Here's some posters. Let's hang them up on the, wherever you put them. You have a bulletin board in the nurse staff room. Do you want to hang it in the bathroom? I don't care where it goes, wherever you think people are going to see it, hang the posters. And then here are these cards we could give out to patients so they could get the patient education materials on their own as well.
And all three of these things have been customized and sent to each site. So everybody is complete on this. So now it's just up to your site to be able to print these materials on your own. If you don't have it or you missed the email and you need me to resend it, just let me know, but everybody should have this.
And like I said, this is a relatively easy part to get done. I see John has posted in the chat to go ahead and order the badge cards sooner rather than later due to supply chain issues, which we're seeing on lots of stuff. And it seems, you know, this is something that's an easy one. This is an easy part to do as opposed to some of the other parts you really need to negotiate. I totally understand it. And like Lizette said, if you have any questions or about this part, send her an email and she can help you with the logistics of it.
Hey, this is Joanne from Lancaster General. Just an FYI, I think I scared Lizette at one point, but when we use the QR code on the postcards for the video, our system blocks it. So you have to work with your IT teams to make this an allowable video to share.
I guess they don't want people watching YouTube while they're at work, and they don't realize that YouTube can be used for patient education as well.
Exactly.
I think they're using it like my kid, not my patient. But that's actually a great point. Thank you. When you try it, don't just try it on your personal smartphone, but try it at work and make sure that link works. Thank you very much for that. That's a great point. Were they able to unblock that one specific site, or how did they do it? Or you're not sure yet?
They're still working on it. I sent it in almost 2 weeks ago, and they're still working on it. There's a lot going on right now, so but hopefully soon.
If you do have a problem, I don't know if you know, it lives on YouTube, but we have it on this other page. If you go to the bit.ly blood clots and you type that in, that takes it to a Johns Hopkins page that has the same video. I don't know if it will play because it's a YouTube video. I think that's a tech question you might have to check out and see, but that might be another option. But the good thing is, if you give it to the patient, they should still be able to play it on their, you know, their personal iPad or their phone or something.
Well, that's I'm looking at my personal iPhone when I do it. It's because I'm signed into the system here. They're blocking YouTube videos. So
wow, they're really controlling your phone. You can't even watch YouTube on your own phone at work.
No, and I can't even shop at Amazon either. So go figure. But anyway.
Now, internally, does your education department develop QR codes for specific education for nurses?
They do not.
Okay, so here we actually have the luxury of having the ability of our education department to develop QR codes specific for nursing education. So you could have them do the bit.ly and then through that department generate a QR code that would link to that bit.ly. But it might be something that if you're having difficulty, or if other institutions are having difficulty, if your education department is able to do that, it might be a way around it.
I will check on that for here at Lancaster General.
Send us an email, you know, between me, Lizette, and Doreen, we should be able to try to help you figure it out. So I think that's another good reason to get started on this part now. Like, this can all be done in parallel rather than in sequence. Okay. Lizette, I think we can keep moving. So then just a reminder of what the bundle looks like. You've seen this before. We don't have to go over this again, but it's this idea of face-to-face with a nurse educator, the paper handout, and then the video that we just talked about. Just a reminder of what that combo looks like. And then Doreen, who you just heard, you know, has the most experience doing this at our hospital and has done this literally for hundreds and hundreds of patients. She is ready, willing, and able, once you're getting ready to turn this on, to come visit in person. You know, we talked about limited by distance and travel, but there's a bunch of places that are close. You know, Maryland is very, very close. Christiana is close. San Diego's a little further. But whatever can't be done in person, she's willing to do via webinar. If there's nurse meetings on the floor, if there's a nurse huddle, wherever you think that it would be useful for Doreen to spend some time face to face, in person or virtually, with the nurses who are going to be doing this, she would be great to kind of explain to them the why and the how. They will have already done the education, they might have already heard about the project, but hearing from a nurse who's done this a ton goes a very, very long way. So she'll be the one who's ready to help anytime you're ready to start to turn this thing on.
Yeah,
Doreen, did I cover it?
I think so. And a lot of times I can answer in real time some of the concerns that people have, especially about the perceived increase in workload. Having done this myself, both holding a pager and also mentoring charge nurses or whatever staff member is holding the notification system, I can walk them through the aspect of that you're empowering and mentoring people to do the education in real time, which actually decreases the amount of pages and missed doses that you'll get.
Yeah, we knew that was a big problem when people were really concerned about how much time the nurses were going to be spending. And once they get in the groove, it's not nearly as long as you think. And then once you really start doing it, there are fewer and fewer missed doses because they preemptively do the education even before the patient's able to refuse. So, okay. We've got 2 more things to cover in the next 10 minutes, and I think they'll be quick. So the first is Chris Holzmuller. We are working on this manuscript on the IRB processes and challenges. Hopefully you've seen this request for everybody. Chris, you're up.
Hi, so just a quick reminder about the manuscript that's describing variation in IRB reviews. Again, want to stress that the plan is for peer review publication with a CLOTT-free group authorship. And so back in January, on the 6th, Lizette had emailed out a relatively short questionnaire to all the site contacts requesting some more information, such as hospital bed size and the number of research protocol revisions requested. It's just like a short, relatively short list of information, as well as sending us copies of the initial and the final IRB applications. We've received, as you can see in this list, we've received from 3 sites. So I'd like to encourage the other sites to, if they can, work on that. It should not take too long, but of course, I'm not the one that has filled them out. So if there's any of the other sites that would like to say how long it did take them to complete, some of them or just like a one, very short answer. So it will be very much appreciated.
And if you go to complete it and there's one thing you don't know, send us what you have. We might send a follow-up email or something like that. As you know, it took almost a year to get all the IRBs approved. Some of the IRBs are research, some are quality improvement. Some were asking, well, what about consent and who's like all these different questions. And I think it is such an important question. We figured out, the large research community has figured out multi-center randomized trials and reliance on a single IRB and things like that. Nobody's figured that out for quality improvement or for implementation science like this. So I think this manuscript is going to help move the field in that direction. So it shouldn't be that onerous. Hopefully you guys can get it back within the next couple weeks. And Chris is actively working on this. Any questions on those, on the survey that went out? Like I said, I think it's like Chris said, 6 questions, not 6 pages. Okay. And then the last topic for the Q&A, Stephanie Armacida is a research postdoc with us. She's going to tell us a little bit about this survey that you should be getting soon. We haven't started it yet. I wanted to talk about it here first, about our expert knowledge helping figure out when we should or should not be holding VT prophylaxis in trauma. So Stephanie, you're up.
Okay, hi everyone. So we discussed or introduced this sub-project kind of briefly at our October meeting, but as Dr. Hout just mentioned, we're getting pretty close to the survey rollout. So just as a reminder, the goal of this project is to explore when it is appropriate to hold peri-procedural VTE prophylaxis. As I'm sure we all know, every institution does it differently, every subspecialty does it differently, even physicians within that particular subspecialty have their own preference for specific procedures. So we are going to use the Delphi method, which is a series of surveys to generate a consensus opinion. Next slide. So what to expect from this is, as we've mentioned, we've generated this survey. It's pretty much near final at this point. So in the coming weeks, we will send you all an email with the survey link and distribution instructions. Really the only ask from you all is just to distribute the initial survey to those providers within the subspecialties of interest, and we'll provide that list. Any subsequent survey we'll take care of because we'll get the responder contact information in the survey, with the goal of being 2 to 3 responses per specialty, per institution. And kind of, as a thank you for helping us with this project, we will plan for a peer reviewed publication with the CLOTT3 writing group, and you all will be credited.
So like Stephanie said, I think the big ask is it's going to come to you, and the goal is we want information from vascular surgeons about the vascular part, ortho from the ortho part, ENT, plastics, urology, et cetera, et cetera. And obviously we don't have contacts at each of your sites. So the idea is to send it out to each of those departments or divisions or however it covers, or would be the ones to ask for their expert opinion on VTE prophylaxis in their specialty. So that's the one big ask. We also do have trauma and acute care surgeons, so we'll want you to distribute that to the trauma and acute care surgeons in your division as well, to get an idea of what they think. But then also, like we said, all these other different opinions from different people. And if we could get, 2 or 3 vascular surgeons from each place, all of a sudden that's 20 or 30 experts from these 10 sites. Same thing for ortho, ENT, et cetera, et cetera. So that's the general idea, like Stephanie said. It is very quick and easy. It's set up. If you click that you're an ortho surgeon, you don't have to answer anything about ENT, plastics, ophthalmology, et cetera. You just get to focus on your piece. So it is made as quick and easy and as painless as possible for everybody filling this out.
Hey Elliot.
Yep.
David Spain. It might be interesting to ask the trauma surgeons what they think about other specialties. So we get a lot of like ortho holding stuff or when I don't think they should. So it might be interesting to ask the trauma surgeons, do you think you should go for an IR procedure or an ortho procedure?
That's a great point. So here's the question. You might imagine we've got figure there's 10 specialties, and we have maybe 5 or 6 or 8 different procedures in each specialty. You can imagine the list for ortho. We don't just say ortho surgery. It has a bunch of different pieces. Do you think it would be too onerous on the trauma surgeons to be offered to look at everything on the whole list? Or do you think that input would be important for people to get an opinion of the Dave Spains, Rosemary Kozars of the world about what they think about, for VATS or, cystoscopy and stent or whatever?
Oh, less about those things, but I think like for us, we finally sat down with our orthopods, and our trauma orthopedic surgeons are fine. Pelvic fracture, femur fracture, they don't care. You can give prophylaxis the morning of, they don't mind. We frequently hold it because we think they're going to mind, but they've actually, so, and same thing with IR. We finally convinced them that for, vast majority of the stuff they're going to drain. But I don't know, it just might be interesting to see if there's a, difference of opinion.
We could certainly do that. I think, it's always this balance of.
And I might just focus like on ICU.
It's a good question. We do have ICU in there. We do have critical care intensivists, for people that are, maybe anesthesiologists who cover in the ICU. We have a series of procedures that they talk about. But we could certainly change that, especially for the trauma acute care surgeons that we think of that take care of the whole patient to get their opinions on it, we could certainly change that, change the questions, or change, not the questions, change the list of people who see which list of procedures.
Elliot, it's Rosemary. I'm just thinking, I like David's idea. I'm just wondering if there could be two versions. So I'm afraid if we send it to every trauma acute care surgeon, it was super long, we wouldn't get any responses or very few. Certainly to send maybe to everybody on the email. I mean, on the, in the group here, and I'm wondering if there just even can be two versions. You can maybe sweet talk some people, just some way to get a big enough sample size, but not to discourage the other people that might do it, if it was a shorter one for them. Just a thought.
Yeah, I think your point is well taken. I mean, clearly, hopefully the people on this call would be willing to take 15 minutes, but maybe the other people are only willing to take 2 minutes. Let's think about what it's going to look like. We will figure that out. But I think, when you think about it, that if each site, we've got these 10 sites, and we've actually added in Hopkins, we've got 11 sites. If each site can get, like I said, even if each site can just get 2 people or 3 people at each thing, we'll have, 20 vascular surgeons, 20 urologists, 20 orthopedics, and a ton of trauma surgeons. I think it will go a long way, because this is an ongoing question. There's not a ton of data out there. And this, I think, would actually help change practice towards what Dave Spain is telling us, that the ortho attendings are like, yeah, fine, we'll do the case. And when, maybe the ortho residents are like, oh, we're not doing that. So clarifying it that way. So to be on the lookout for it. And then David's point about intensivists as well. We might have to change it up a little bit to see that we get enough input from enough people on it. But thank you. So that was the majority of the meeting today. Obviously, it's recorded. If there's people that missed it, please tell them to go watch the recording. Lizette will put it up there. A couple quick plugs. The first of which is we have a center, and we have a project that Todd Costantini and I are the co-PIs on for 2022 consensus conference to implement optimal VTE prophylaxis and trauma. It's going to be a hybrid virtual combined meeting. You can grab the QR code. If you need more information, send me an email or send Michelle an email. We have a series of early stage investigator travel awards. So if you've got a junior faculty member that is interested in this topic and wants to get involved, we're going to have some travel awards so they can come to the in-person part. It's going to be open widely, hybrid version as well, for people who want to watch it at home that don't want to travel to Chicago for those couple days. Tons more information. You can get more from me or Michelle. Just send me an email and I can send you more information about it. And then the last slide, the originally scheduled meeting was on February 21st, which is President's Day. So we thought that we should move it, as many people will be potentially off, not working that day, et cetera. So we're going to plan to move it to February 28th. We thought moving it a week later is better than moving it a week earlier onto Valentine's Day. So that change of date will be out, or will be coming shortly for that. With that, I know we're at time. Any questions that the group wants to ask overall? And if not, obviously we're all available via email if you want to get in touch with us. Okay. Thank you all very much. I know it's been a lot of work, and it's exciting to see. I mean, it's exciting to see 850 nurses have done this education across the country, and it's exciting to see we're getting close to starting to get some data, doing the implementation and getting it going. So thanks again for all the hard work.
Thanks, Elliot.
Thanks.
Thank you.